Hello and welcome to this presentation on benign prostatic hyperplasia. My name is Dr. Naomi Dry and I'm a core surgical trainee and will be taking you through this lecture. I do hope that you enjoy it. A short disclaimer before we begin. This is a video made in collaboration with the Association of Laparoscopic Surgeons of Great Britain and Ireland, and a special thanks to Mr. Coley for his leadership in this. It is focused on educational purposes for the MRCS. Enjoy. We will begin by talking a little bit about the anatomy of the prostate, then move on to discuss pathophysiology, epidemiology, presentation, investigation, various managements, and just to cover TERP syndrome at the end. I imagine the prostate as an upside down pyramid. Its superior base is in contact with the base of the bladder. Inferiorly, its relation is the urogenital diaphragm, where the urethra continues as the membranous urethra. Posteriorly is the fascia of Dino Villiers, which separates the prostate from the rectum, and then laterally it is encased by the pubo-coccygeal portions of the levator ani. The prostate is divided roughly into 70% glandular tissue and 30% fibromuscular stroma. It is then further divided into 4 zones. The anteriorly is the fibromuscular stroma. Then you have the transitional zone, which surrounds the urethra, the prostatic urethra to be specific. The peripheral zone makes up most of the gland and sits at the apex and posteriorly, and then finally the central zone surrounds the ejaculatory ducts. And then some final facts to conclude the anatomy of the prostate. The arterial supply is from branches of the inferior vesicle and medial rectal arteries. The venous drainage is to the prostatic venous plexus into the internal iliac veins, and then some drainage into the vertebral venous plexus. This is thought to account for the spread to the lumbar vertebrae of prostatic cancer. The lymphatics is to the internal iliac nodes, and its nerve supply is essentially the sympathetic innervation, which causes relaxation of the prostatic tissue by alpha adrenergic receptors. So, BPH is essentially a non-cancerous increase in the stromal and glandular elements of the prostate. Most commonly it occurs in the transitional zones and surrounds and compresses the urethra. The mechanism behind it is a little unclear, but it's thought to be androgen dependent. BPH is a very common disease. In those that are over 80 years, 90% of men will have an element of BPH. And even at 50 years of age, 40% of men will have BPH. Other risk factors than age include family history, Fibro-Caribbean ethnicity, and obesity. So BPH can present in many ways. It can be completely asymptomatic. Most commonly, it presents with LUTS, that's lower urinary tract symptoms. These can be either voiding or storage symptoms. Voiding symptoms include hesitancy, poor flow, dribbling, or incomplete emptying. This may be the patient describing going to the toilet twice within 20 minutes. Storage symptoms include frequency, nocturia, and nocturnal enuresis, and incontinence. They can also present with hematospermia or hematuria. Acutely, they could present with acute retention or acute on chronic retention. On examination, you'll find a large and smooth and equal prostate. The IPSS, which is the International Prostate Symptom Score, is a way of quantifying these symptoms and essentially giving a number that defines the severity of the patient's symptoms. There are a number of investigations you can do for someone with suspected BPH. There's simple things include a urinalysis looking for hematuria, which may warrant further investigation with cystoscopies and imaging. They may also fill out a frequency volume chart, which will give lots of information about their fluid intake. They should do flow rates, which would calculate their Q max, which should be greater than 15%, and they must void over 100 mils. You can also do a post-void volume after this. You may also send some simple blood tests and include a PSA in this and a use and ease. An ultrasound scan of the urinary tract can be helpful in assessing for upper urinary tract symptoms or abnormality such as hydronephrosis and assessing the volume of the prostate. A prostate larger than 30 mL is often considered to be enlarged. Finally, urodynamic studies are sometimes used in the diagnosis of BPH. However, this is often only if the diagnosis is in question. You can calculate a bladder outflow obstruction index, which uses the detrusor pressure and minuses the Q max. Anything greater than 40 would indicate an obstruction. So moving on to the management, this can be conservative, medical or surgical. So conservative management includes reassurance. Sometimes you do not need to do anything and a patient may just need to know it's not cancer. Reduced fluid intake can help, and reducing caffeine intake also can relieve symptoms. Okay, the medical management involves two main types of drugs. These are adrenergic antagonists, including tamsulosin and alfuzosin, and 5-alpha reductase inhibitors, including finasteride and dutasteride. Androgen antagonists block the alpha receptors and reduce the tone of the prostate. Some side effects of these include postural hypertension and retrograde ejaculation. 5-alpha reductase inhibitors block the conversion of testosterone to dihydrotestosterone, which is more potent. Side effects include sexual dysfunction, but this is thought to be short-lived and patients can be reassured. Okay, finally, the surgical management of BPH. Our gold standard treatment is still thought to be your transurethral resection of the prostate, and the most commonly used method now is that of bipolar. The traditional version is the monopolar. This is removal of the tissue transurethral. There are a number of complications though, which is why there is lots of work into other procedures. Complications include hemorrhage, retrograde ejaculation, TERP syndrome with monopolar, strictures and incontinence. For smaller prostates, those less than 30 mL, transurethral incision of the prostate may be sufficient. There is also guidance for prostates over 80 mL that a simple prostatectomy, open or minimally invasive, should be offered. However, this is often not put into practice. Some newer methods of treating BPH include HOLEP. This is a laser enucleation of the prostate tissue. Urolift is essentially stapling up and back the prostate. Prostatic artery embolization is what it says on the tin, embolizing the prostatic artery, which causes atrophy of the prostatic tissue, and then vaporization of the prostate tissue. TERP syndrome, although now rare, is probably the most worrying complication of a TURP. It's due to the absorption of hypoosmolar irrigation, the most commonly used glycine, through the prostatic venous plexus. It results in fluid overload and hyponatremia. A patient will become confused, nauseous, agitated, visual changes, have bradycardia, hypertension, and eventually they will start to have seizures and decline into a coma. They will need management, likely in ICU, with fluid restriction and diuretics. Thank you very much for listening. Here's a bonus quiz to finish off and see how much you have retained. All the best. Take care. Bye-bye.